I am David Mankoff. I'm from the University of Pennsylvania. I'm one of three Komen scholars that are at Penn. You heard from one this morning, Angie DiMichele, who's one of my colleagues. And there's also Susan Domchek, who runs our Vassar Center. So the three of us are Komen scholars. Actually, Susan and I have been doing this for quite a while. So this is really a wonderful organization to sponsor these kinds of events. And one of the things I really admire Komen about is thinking about metastatic breast cancer, which in many other efforts and organizations doesn't get thought about. I am, by training, an imager. I'm a nuclear medicine physician. That makes me a little bit of a rare bird in breast cancer research because most folks are working on treatments or perhaps primary breast imaging like mammography and MRI for detection. I work on things that revolve around radioisotopes, often called molecular imaging because we're imaging molecules. And by the nature of how it works in things like bone scans and PET scans, and I'll talk more about that today, this is a specialty that is really well matched to staging breast cancer, seeing how metastatic breast cancer responds to therapy, and as you'll see, guiding treatment in some of its latest innovations. So it's really a great pleasure for me to be able to match up this expertise with folks who are going through this or who have an interest in it. So thank you all for being here. This is meant to be very informal. I have a few slides, lots of times for questions. So I wanted to start with a couple of questions here. If I can ask who has or has been associated with somebody with metastatic breast cancer? I've definitely had family members in that regard. Great. Anybody had a bone scan before or know somebody that has a bone scan? Okay. Anybody had a PET scan or know somebody that had a PET scan? Okay. The more and more hands going up in this crowd than there were in prior areas. So I'm going to shed a little bit of light on how these technologies work and where they may be going, including some research that has been sponsored in my group, including on how to be able to use this type of imaging, not only to find the breast cancer, but how best to treat it. I want to acknowledge some of the people that I've worked with that have contributed slides, both at Penn and my former institution at the University of Washington. I do want to disclose I am a consultant for GE Healthcare who makes Cerianna, and I did eat one of their cookies, so that's my conflict of interest. Let's start with a couple of things, but please interrupt me. Raise your hand if you have a question because it's meant to be interactive. Okay, so the aspirational components of today's talk are: what if we could identify patients with metastatic breast cancer earlier and more accurately, and perhaps more conveniently? Number two, what if we could determine if treatment is working in cases where it can be very tough and early? So if we've picked the right treatment, great. If we haven't picked the right treatment, there's a lot of treatments these days and we can move on. And then finally, what if we could actually use this imaging not just to find cancer, but to help you decide how to treat it? In the metastatic setting, the cancer is spread in a lot of different places, and there's no guarantee it's the same in each individual location. So the ability to use imaging to characterize the tumor at all of the sites of disease should provide us a significant advance that is complementary to what we can get out of a biopsy. Okay? So that's where we'll be going today. All right, this is just a brief update to show you the different things that are associated with imaging. I'm sure many have heard of things that are involved in screening and detection. I'll put up my answer key here. There's mammography and the more modern version of mammography, digital breast tomosynthesis. These use x-rays. These use low-level x-rays, kind of like a chest x-ray, to be able to image densities in the breast. Ultrasound does not use radiation. It uses sound waves, again, to image some of the physical characteristics of the breast. And then a breast MRI uses magnetism and magnetic imaging to look at breast tissue, and in particular, because it gives contrast that is associated with vascularity, with blood vessels, abnormal blood vessels in the breast, it has been a good way to detect breast cancer because often, especially invasive breast cancer, is associated with angiogenesis or increased abnormal vessels. Now, when we think about staging, so we've found the breast cancer, but we want to have some idea of where it has spread. And we're thinking even beyond the axillary nodes to other parts of the body, which is by definition what we call metastatic breast cancer in most cases when it's spread outside of the breast and regional nodes. So we have standardly used CT for that. That's also an X-ray based technique. It's a three-dimensional X-ray. If you've been going through the CT tube, you're getting a full circle of X-rays and using mathematics to reconstruct that. Two people won the Nobel Prize for that in the 70s. And it's really revolutionized the way we practice medicine in general. But it still looks at things like density, shape, size, to infer where sites of disease are and whether they respond to therapy. You can also do whole body MRI. It's a little trickier. MRI takes a long time to do, and it's good for getting one part of the body. It's a little harder to do whole portions of the body. And then we have nuclear medicine, which is what my specialty is and what I'll be talking to you today, and that is radioisotope imaging. Okay? Radioisotope imaging sounds a little creepy, doesn't it? I'm going to give you a radioisotope, and I'm going to have you swallow it, or in most cases inject it. You do not lose your hair with it. You don't shoot giant webs, because that's Peter Parker was bitten by a radioactive spider, remember? So if we could actually have people shoot webs, we'd probably get more customers. Every now and then around Halloween, somebody will say, well, I glow in the dark when I do this, and I go, only if you've got scintillation crystal eyes will that happen. So it's a really actually relatively low dose, relatively non-invasive approach to this. All right, so what if we could find breast cancer earlier and with more accuracy? Right, so the standard approaches for staging, okay, and again, these are patients, this applies to folks who have had breast cancer diagnosed, and we're really trying to decide whether or not the breast cancer, or understand whether or not the breast cancer has spread anywhere, and if it has spread, is it going away or coming back? So that's an example of a CT. What we do electronically, not physically, is I cut the patient in this way generally, although we can go in any direction we want. You are looking up from the feet. So what you're seeing is this is the right side, that's the left side, the front of the body, two breasts in the front of the body, and then in the background. The dark stuff is actually not very dense, so all of this is lungs. That's why it's so undense, and we can change the windowing so we can look at the lungs. And the stuff that is white is quite dense, and that's the bones. Right? This is a bone scan, which is used quite widely to be able to detect bone metastases. And it works quite differently. What happens is your bones are replenishing themselves all the time. They're eating themselves away and building new bone, and that's the way normal bone works. Osteoblasts and osteoclasts we learned in medical school. When a metastasis goes to the bone, it hijacks that system and usually results in either too much deposition of bone or, in many cases in breast cancer, too much eating away of the bone. And it causes increased bone turnover. The bone scan actually looks at the formation of bone, and so it can be a very, very sensitive way of identifying bone, not so much because of its structural features, but its biochemical features. Let's go on to PET scanning. This is what happens when you've had a PET scan, when you've been in this system and then we generate this image. This is everything that has happened that day. Somewhere there's a cyclotron. This happens to be under the nursing building at the University of Pennsylvania. They didn't like us at first. We told them there's no radiation coming from this. It's very safe. It makes this F-18 compound, which looks exactly like fluoride, but it's a different isotope, behaves exactly like fluoride, but it only has a 2-hour half-life. So we got to work hard to be able to make the chemistry in this gleaming facility to do it safely every single day, and we make something that looks a lot like a sugar with that one substitution, that F-18, that is able to image isotopes. We inject it into a patient. You can see why I was not a medical illustrator. It's red, and the patient's always smiling. And then we put them into a donut, and the donut kind of looks the same, whether it's a CT scanner or a PET CT scanner or a PET MRI scanner. And in particular, when you're going into a PET scanner, that positron makes these pairs of photons, these pairs of high-energy X-rays that are called annihilation photons. Now, that's not because you get annihilated if you happen to be in the patient. These are matter-antimatter, and when they find each other, when a positron and an electron find each other, they release this energy, and it makes for a very accurate and convenient and flexible way of approaching it. All right, I see some folks who are probably in the same vintage of watching TV that I was when I was young. Anybody know where matter-antimatter showed up in a popular science fiction TV show and movie? If this were guys here, they would have gotten this, because Trekkies. The Starship Enterprise that's how its engines worked, is matter-antimatter. We have not had anybody go into warp drive from our PET scans yet. Now, when we're all done, after all this fuss, why do we do it? And what we do is we get an image of tracer concentration, and that tracer concentration represents something very specific. And in this case, for the most conventional PET scan using fluorodeoxyglucose, what we're imaging is sugar consumption, is glucose consumption. Now, why do we do that? People go, oh my God, should I not have these Ariana cookies anymore? And sugar is just a basic fuel that goes throughout the body. One of the features of tumors is that very generally, especially the most aggressive tumors, will use too much sugar compared to the rest of the body. And so when we give this tracer, we can measure regional glucose, regional sugar metabolism consumption, and we can see things that we would otherwise not see. And in this case, we see the primary breast tumor in this fused image that has this metal scale, which is our PET scan on top of a CT scan. And this allowed us to find spread to these lymph nodes that live inside the chest that are otherwise very difficult to identify, but can be very important in directing therapy, including directing very selective radiotherapy. So that's the big deal, is why we do this, because we're able to image biochemistry, not structure, and leverage some of the abnormalities that are present in tumors that are not in the rest of the body. Okay. So some people say, well, why don't you just tell people not to have sugar or give them some radioactive sugar and cure their cancer? And there's a big problem with that. If we were to do the whole PET scan, what do you think the organ that has the highest level of uptake is? The brain. Maybe the people watching my lectures, it's a little bit less than others. But it's just one of these things that is such a fundamental consumption area. It's useful for being able to do detection, but it is not really a therapeutic target. The other thing that happens is people say, why do I have to go get a brain MRI if I just had a PET scan? And part of the reason for that is that with deoxyglucose, there's so much uptake in the normal brain, it's not as good as detecting those metastases. So if there is some suspicion or desire to make sure that there's not a brain metastasis, brain MRI right now works far and away the best. There may be some exceptions in the future. Okay, let me stop. Questions? I throw a lot of stuff out at people. I see people nodding, but... Okay, so here's another similar example to what I showed you before. Here's a patient who we knew had a relatively advanced breast cancer on the right side. We knew that patient had spread to the armpit, to the axilla, and that was all fairly obvious from physical exam, so treatment was planned based upon that. But because of the implications of this, in some cases, they'll do a variety of things, including giving the chemotherapy before going to surgery. And when you do that, it's important to know where you started from in terms of the cancer. And in this case, the fact that there had been spread to the internal mammary nodes and the mediastinal nodes, which is another pathway that shows up in some but not all tumors, that's very important information. Number one is, if we're going to use chemotherapy to get rid of the disease, we want to get rid of every site that we know about. Secondly, let's suppose this patient has a very good response, which she did. She would have surgery in the axilla, surgery in the breast. You can't really go in and crack the chest and pull those lymph nodes out. So she'd get very focal radiation to that area, and they'd actually use the PET scan to help guide that radiation to try to minimize the toxicity and maximize the benefit. So these staging studies have been very important, and in particular, and this is something I was involved in early in my research, we were identifying those nodes in that location really much better than just about any other modality at this point. Okay. So everybody goes, why shouldn't everybody get a PET scan, right? I got my breast cancer diagnosis, I want a PET scan, and why shouldn't we do that? And there are some lessons learned early on in this process, and some of our research participated in that. And that is, if you are very early stage breast cancer and don't have symptoms, your risk of having spread elsewhere is quite low. That's part of the reason we go for early detection. If you have, say, just a few percent chance of having distant disease, no matter how perfect our test is, no test is perfect. And under those circumstances, when the chance of finding something is very low, the chance of finding a false positive, something that's not there, is even higher. So, could it ever be harmful to do too much diagnosis? Actually, yes. It's a very hard concept for folks to understand. If there's low risk of finding something and high risk of finding a false positive, not only do we delay care, we increase anxiety. And so an experienced physician in this field will say if you do not have symptoms and if you have a small cancer and no sign of spread, then you really don't need systemic staging. And in fact, doing that systemic staging in the absence of some symptoms like bone pain could be actually detrimental to your care. It took a long time for us to learn that. So, anybody had that wonder, why don't you just scan my whole body and tell me where everything is? That's part of the reason we don't do that routinely. When the disease is more advanced, then it starts to make sense. All right, what if we could determine treatment is working early, maybe soon after we start treatment? That'd be kind of cool. All right, so I am going to turn you all into nuclear medicine physicians, right? Okay. So here is a patient that had a bone scan. These are old bone scans. They're not the best quality. And just take it my word for it that you see some abnormalities. You see too much uptake in the pelvis and the spine. And so just take my word for it that that pre-therapy scan shows what is actually fairly widespread bone metastases. The patient went on to have treatment and had another bone scan at 3 months. How many people think the patient's responding? How many think the patient's progressing? How many patients think, oh my God, I'm really glad I'm not a nuclear medicine doctor? Everybody raises the hand. So this was the state of the art until PET scanning came along. And actually, when I first started on faculty at the University of Washington, one of my colleagues, who's actually now the medical director of ASCO, Julie Graylow, came up and said, we have so much trouble with this disease. Could PET scanning help us? So here's the answer. All right, how many think this patient's gotten better? Here's somebody with diffuse disease that's very dark, and all of the bones, the breast cancer will spread sometime, but you can see how much decrease in glucose metabolism there has been over time. And so this is emerging as the preferred way to measure bone metastasis response. Why is that? Because when a cancer spreads to the bone, the abnormalities you see on the bone are actually not a direct impact of the tumor. The tumor hijacks the underlying bone system and either causes too much of the tumor to be deposited or too much tumor to be eaten away. And so as you start to fix that process, the bone starts to repair itself. It's very confusing to know whether you've got worsening bone metastases or better or no change. Because you're not imaging the tumor, you're actually imaging the associated process. But here, with the FDG, with the glucose, we think, and we're still working out some of the details, but we think this is actually imaging the tumor and some of the processes that eat away at the bone. And it's been a much more effective way of doing this. Around the country, many patients who have most of their metastatic disease in the bone will get serial PET scans as part of their primary follow-up. And this is some of the data that supports it. I will tell you, we're just about finished a national trial called FEATURE, ECOG acronym 1183, that is designed to make this the standard of care. One of the things that happens is patients with metastatic disease to the bone can't get into clinical trials because it's been so hard to evaluate whether or not they're responding or not. And the hope from this study is that we'll be able to take folks with bone-dominant breast cancer, which is very common, especially in estrogen receptor-positive tumors, and make them much more widely eligible for clinical trials. And importantly, make it easier to follow their disease. So have anybody in the room had a bunch of PET scans to follow disease that way over the course of treatment? Okay. But for those that have metastatic breast cancer, it's commonly used technique. All right, questions. I'm going to go on to the last piece of my presentation, then I'll open up to take any other questions you have. All right. So the last piece is something that I've been working on throughout most of my career. Finally led to an FDA approval, which is called Cerianna, about 2 or 3 years ago. And the goal here was not only to find breast cancer, but to guide its treatment. All right, so here is a diagram of the estrogen receptor. People heard of estrogen receptor positive before. So the estrogen receptor, I'm going to take you through a biology lesson, is a nuclear receptor. That means that it's not nuclear in the sense that the isotopes are, but it's sitting in the cell nucleus, which is right near where the DNA is. And so what happens is they work as pairs. When the estrogen, which is estradiol, or oestradiol if you're British, binds to that estrogen receptor, they pair together, and then they go out and program, they carry out a program of gene transcription, of activating genes that are involved generally in female physiology. The interesting thing is this is a different program in the breast than the uterus or the bones or other places, and it acts a little bit differently in each location. In the breast, this is very important in developing the breast mammary glands to be able to promote lactation. And so when that happens, you have to increase proliferation. You need to make more cells to be able to make the milk. You increase your glucose consumption. We see that. You need more fuel. You need more blood vessels to support all of that. And you do all the things that a tumor loves to do: proliferate, use fuels, have blood vessels. And so tumors, which are unfortunately smarter than us sometimes, figure out how to hijack these underlying mechanisms. And one of the most popular ones to be hijacked is the estrogen receptor. Now, once those tumors become dependent upon the estrogen receptor, then it becomes a very important target. And those targets include blocking the estrogen receptor with something like tamoxifen, which is called a selective estrogen receptor modulator, or SERM, or being able to reduce the amount of estrogens both locally and globally in the body using something called aromatase inhibitors, letrozole. If anybody's ever taken letrozole, that's one of the aromatase inhibitors. Now, the interesting thing is if the estrogen receptor is present, then there's a very good chance of responding to the treatment. If the estrogen receptor is absent, if you happen to have a form of breast cancer that does not have the estrogen receptor, then the likelihood of treatment success is quite low, almost zero, and it directs you towards other treatments. So how do we do that now? Or how had we done that up until now? So we take a tumor biopsy or tissue at the time of surgery, and we go in and do special staining to look for the estrogen receptor. The way that was done when I was just finishing up medical school, which was when dinosaurs ruled the earth, was to actually take something that is labeled with a non-imageable radioactivity tritium, put it in a test tube, see it bind to cells, and see whether or not that binding is present. I'm not trying to turn you into biochemists here, but that was the old way of doing it. That was pretty klutzy, and once we were able to make monoclonal antibodies, which won somebody a Nobel Prize a while back, we were then able to make antibodies that could detect the estrogen receptor, called immunohistochemistry. So everybody who's had breast cancer has had your tissue assayed by immunohistochemistry that included things like the estrogen receptor, the progesterone receptor, HER2. That's how it works. And this has become the gold standard. But what's interesting is we started with a radioactive binding process. Well, what have we done now? We can take F18 fluoroestradiol. What is fluoroestradiol? It is estradiol that has an F18 on it so that you can image it with a PET scanner. So we're back to the idea that the way we measure receptors in the body, in the patient, not in a piece of tissue, is by using a PET scan that has estrogen. And in fact, what we can show is that in these images, and if you're not a nuclear medicine person, these are coronal images. We slice you this way electronically. And then on one side is an FDG scan, and that shows you all the areas of abnormal sugar uptake, in this case, number of nodes in the chest. And on the right side is uptake in all of those sites that shows that it bound estrogen. So every single one of those sites, without having to do a biopsy, we have learned from this, can bind estrogen. We've had large multi-center trials that have compared the imaging to the biopsy and to show that we can get the same answer. What you also see here is these estrogens are a steroid. All steroids get metabolized in the liver, and they actually make it through the bowels and into the bladder. Now here's a patient that had recurrent breast cancer that was ER positive before it recurred, and there were 2 spots in the chest similar to that other patient that showed up. However, that patient did not bind the estrogen, and in fact, and you wouldn't know this unless I told you, it's actually binding to the uterus, which is a place that normally has a lot of estrogen receptors. So we knew the tracer and the technique was working, but we knew that those sites weren't binding, and at biopsy they turned out to be ER negative. So we can identify metastatic disease across the entire body that is either still estrogen receptor positive or has lost its estrogen receptor. This patient will likely to or has a good chance of benefiting from endocrine therapy. This patient won't. So in addition to having another way to identify the disease, all of a sudden we have a way in the metastatic setting of being able to guide therapy. So imaging moves from a tool from just detecting therapy and maybe measuring its response to actually helping oncologists select what type of treatment might move there. This is the first of this type that's been done in all of medicine. It was approved this way. We were just talking about how difficult it is sometimes to get this rolled out into the clinic and get people to accept the idea. But I think this is a landmark instance in which we can begin to use these tools, especially for metastatic breast cancer, where it's really tough to tell what's going on. And if I sound enthusiastic and I sound like I'm selling you something, I've been working on this for a long time, and it's really exciting to see it get out into the clinic now. All right, so is the target present? So here's a picture. I think it's actually in your brochure, this one, right? This is the Bohr study. It's a very nice, it's a great study. I quote it quite a lot. And so the patient on the top has every single site that shows up on our sugar scan also show up on the other scan. I won't assign you the homework of matching all the sites together. And ends up having a very good response. The patient on the bottom had some sites that had uptake and had preserved the estrogen receptor, but you can see there's a lot of sites, especially in the bones, that are missing, and that person went on to progress in that treatment. So in the modern instance, this person now would probably get a different treatment now that this evidence is progressing. This person up here, we'd say, hey, it's all matched, let's give it a try. Sometimes it works. We usually find out early if it doesn't, but every now and then it doesn't. And the bottom, that patient you could have predicted was not likely to get a good response. And we can save that patient a futile cycle of therapy that's unlikely to work. All right. This is also a different for those that may have had experience with lobular breast cancer. It is a really sneaky cancer that's very hard to find and very hard to track. Lobular breast cancer is one of the most reliable expressors of the estrogen receptor, and so we're starting to have data. It's early in the process that this particular tracer may be helpful for metastatic lobular breast cancer, which is a very challenging condition. Okay. Last but not least, we can be able to look for heterogeneity, differences in expression over the different places. We're also now having the ability to measure circulating DNA. And this is DNA that is coming from the tumor and that tells us that the tumor may be coming back or getting better or getting worse, but it also tells us something about the tumor. And the ability to look at the heterogeneity of these gene expressions, the heterogeneous composition across the tumor site based upon these blood samples and match them with imaging, to me is the future of where we're going in treating widespread disease. In ECOG-ACRIN, we just had a whole session that I helped run a few weeks ago on this being really the future of diagnostics and guiding treatment. So with that, what if we could do all of this? We actually can identify spread earlier with many of these techniques. We can actually determine sites of disease that are responding where we couldn't do that before. And I think we're beginning to see the era of not only being able to detect this disease, but be able to guide treatment. Not everything that we're doing here isn't widespread available. There's a bunch of stuff that's still in research that's still being tested. But I think you're going to see this roll out over the next few years as a really important diagnostic adjunct to help people guide all the different treatments we have in breast cancer. The great news is breast cancer, of all the solid tumors, has probably given us the most variety of treatments. The challenge there is we need something to tell us how to use those treatments and which ones to choose. And this, I think, is going to be one of the tools that helps us do that. Okay, well, thank you very much. This was a very spirited and engaged discussion. And I feel like this has been happening for a long time, and I'm really excited about this era where we have both the diagnostic technology and the therapeutic technology to make some significant advances. I do want to come back to what we talked about is I would encourage you, if you're patients, to participate in clinical trials, encourage your friends to participate in clinical trials, because the evidence that we need to build up to know what is the right thing to do is really important. And I think in the metastatic setting, it may be as important as any other place, because there's so many choices. But thank you all.